All right, I think we can go ahead and get started. Hello, everyone, and thank you so much for joining us for today's special session of the KCI Institute Lectures, Living with Macular Degeneration and Low Vision. Today we have Macular Degeneration, Innovations and Insights presented by Dr. Stephen Bailey and Dr. Christina Flaxel. Doctors Bailey and Flaxel are retina specialists at KCI and are involved in a number of research studies of age-related macular degeneration. My name is Ellie Inns, and I am on the Protocol and Events team here at OHSU, and I'll be acting as your moderator for today's session. I'm going to quickly go over some housekeeping items for the meeting before kicking it over to your presenters. During the question and answer section of today's talk, we'll be answering emails sent in before and during the event. Please feel free to send in your questions at any time to conj@ohsu.edu. If you have any technical issues, please email minors@ohsu.edu. Please note we are also recording this session for later viewing at the KCI Institute webpage, and that's www.ohsu.edu/AMD. You can see all of those emails and web browsers on your screen here. And with that, I'm going to turn it over for your speakers, Dr. Bailey and Dr. Flaxel.
Hi everyone, I'm Christina Flaxel. I'm going to be starting out this meeting today talking about some innovations in macular degeneration research. I want to thank everybody for joining us and also thank our donors who, without their help, we would not be able to have these sessions, and also all the donors to the Wold Family Macular Degeneration Center. So let me get started here. So I'll start with some background information. Macular degeneration, as we all know, is one of the leading causes of severe irreversible visual impairment in developed countries. There are 11 million people affected with macular degeneration in the United States. And by 2050, it's thought that 22 million people will have macular degeneration. That's just in the US, and greater than 250 million people will have this worldwide. The global cost of visual impairment from...
Dr. Flaxel, sorry to interrupt you. Your screen share is not on at the moment.
Oh, okay. Let's see what I did wrong. Okay, so we'll start over here again. And I assume you heard me thank everybody. So sorry about the screen share issue. I thought that was working, but we'll start at the background. The macular degeneration is a leading cause of severe irreversible visual impairment in developed countries, with 11 million people affected in the US, and by 2050, 22 million people will have macular degeneration, with over 250 million people worldwide affected. The global cost of visual impairment from macular degeneration will be $343 billion is an estimate, with $255 billion in direct healthcare cost. The prevalence of visual loss increases with age. The age group of people who are 52 to 64 with signs of macular degeneration, only less than 2% of those patients will have visual loss, 10% for patients ages 65 to 74, and 30% for patients 75 to 85. The older you get, the more likely you are to lose vision from macular degeneration. 12% of people with early macular degeneration will develop the late or severe form of the disease over 5 years. Overall, macular degeneration is responsible for about 46% of severe visual loss, with visual acuity of less than 2200 in persons over the age of 40 in the United States. The neovascular form is responsible for 90% of cases of severe visual loss. That is also the wet form of macular degeneration. The prevalence varies with ethnicity. The Caucasian and Asian populations are at higher risk of late macular degeneration than our Hispanic and African populations. There is a genetic component with the disease, but the disease is felt to be multifactorial. That means multiple things go into whether you're going to have the disease or not. Environmental, dietary, medical, and lifestyle factors can influence the incidence and progression of the disease. The main risk factors for the development of advanced macular degeneration are increasing age, ethnicity, and genetics. Cigarette smoking is the main modifiable risk factor. That means something you can modify yourself. So we know that cigarette smoking, if you smoke cigarettes, you're at very high risk of developing macular degeneration. So if you smoke, you should quit smoking. No matter what your age, it is better to not be a smoker than to be a smoker. Levels of antioxidants, vitamin E above the original AREDS dose should be avoided. And elimination of beta carotene was done, which may reduce the competitive absorption of the antioxidants lutein and zeaxanthin. And the most recent form of the AREDS vitamins does not have the high dose, does not have beta carotene at all in it, and that was replaced with lutein and zeaxanthin. A Mediterranean diet is recommended, and in some studies, caffeine may be protective. There's been a new study that looked at the AREDS and the AREDS2 data, and this also showed an mildly increased risk or a possible increased risk with high fat intake. So it's recommended that people avoid a high fat diet, and this probably also plays into some of the genetics, but that hasn't been exactly worked out yet. There have been varying reports about aspirin. In a large meta-analysis of 10 studies with over 171,000 patients, the use of aspirin was not associated with an increased risk of macular degeneration. So it is recommended that patients who are on aspirin therapy should continue their aspirin therapy as prescribed. This is known to be a polygenic disease. That means that multiple genes are most likely involved in the disease, and there are multiple genetic variants, and we'll talk about some of the studies that are looking at these specific genetic variants and how to actually treat those genetic variants. The risk of developing the disease is 3 times higher in people who have a family member with macular degeneration than in those without a first-degree relative with AMD. The complement pathway, as we'll discuss later, is also very important. This is an immune response system activated by antigen-antibody complexes, and there are drugs now that are targeting the complement pathway. The genetic variants discovered to date explain about half of the classical sibling risk of macular degeneration. And commercial genetic testing for some AMD risk variants is available. However, at this time, results of genetic testing do not alter our clinical management. Routine testing is not recommended in general for improving patient care or altering risk reduction recommendations. So I'm going to go on to clinical trials now. This is a slide I had from 2014, and this looks at the number of worldwide macular degeneration clinical trials. And you can see the numbers here because we're going to go over a couple of years. So this is 2014, that was 6 years ago. And just in the US, there were 119 macular degeneration studies. This is 2017, so 3 years later, in the US, there's 638 studies, and you can see the number of studies worldwide has increased. And this is as of 2020. We now have 775 macular degeneration study trials in the United States, and worldwide, the numbers have also increased fairly dramatically. So more and more trials are coming up pretty much every day in macular degeneration. I got more emails yesterday about some new studies that are starting. So it's very, very exciting right now in the world of research for macular degeneration. Our current treatment involves lifestyle modifications, the use of AREDS2 vitamins, and anti-VEGF injections for wet macular degeneration. There's 3 drugs which we use now. There's actually a 4th drug which is available. And I'll discuss these drugs, the newest drug, a little bit about its availability and why it's not being used routinely at OHSU or KCI Institute. The 3 drugs we routinely use are bevacizumab, ranibizumab, and aflibercept. The common names are Avastin, Lucentis, and Eylea. Our treatment goals with the treatment of macular degeneration is to improve the outcomes, decrease the visits and the treatment burden. A lot of times people need to come in on a monthly basis, and that's a lot of visits, burdensome on not only the patient but the family. We want to increase access as well, and we would like to be able to decrease the cost. The cost of these drugs is really, really high, and it would be nice to be able to supply drugs at a lower cost to both the insurance and the patient. So I'm going to get into some of the clinical trials, and I'll start out with some of the dry macular degeneration studies. Metformin is a drug that's used to treat diabetes and has been found to reduce oxidative stress as well as inflammation, potentially slowing the rate of progression of geographic atrophy. So this is a drug that we use for dry macular degeneration right now. It's also a drug that's commonly available to treat diabetes. Qualifying patients for this study are randomized to either oral metformin or observation. And both groups are followed every 6 months, which is the common way that patients with dry macular degeneration are followed. And this is the eligibility requirements. So older than 55 years, no diabetes, and not currently on metformin, visual acuity either really good or not so good, and no prior injections of any anti-VEGF agents. Another study that we're doing right now is the gyroscope for dry macular degeneration study. This is there's a one-year observational phase in this study following genotyping for a specific genetic variant. Approximately 3 people in 100 will have this rare variant. And those entered will then be randomized to receiving a subretinal gene therapy injection in the treatment phase of the study. The first patient in that treatment phase in the US has been treated a month ago in Reno, Nevada, and received the gene therapy. We are currently in the observational phase right now at KCI Institute, and we have been approved to enter the next phase, but we have not entered any patients into that phase yet. The Gallego Study for dry macular degeneration is another dry AMD study which we're carrying out at this time. There's an antigen binding fragment, which is called an FAB, of a humanized monoclonal antibody, which is directed against an agent called HTRA1. This HTRA1 protein product increases your risk for macular degeneration. Inhibition of this HTRA1 should decrease the overall amount of this protein in the eye and hopefully decrease the growth rate of dry AMD. Patients are randomized to either the drug or the placebo, and these drugs are given by an intravitreal injection either every 4 or every 8 weeks for 2 years. Entry criteria is geographic atrophy or significant dry macular degeneration with no evidence of wet macular degeneration. Patients need to be over the age of 60, and they have to have vision better than 23/20, which is basically the big E on the eye chart in the study eye. There's also some lesion size and criteria which must be met, and it can have no other ocular disease. Complement inhibition in dry macular degeneration. That's another hot area of research right now. 54% of dry AMD patients with drusen are estimated to advance over 10 years to geographic atrophy. The complement pathway is the body's innate immune defense system. Genetic variants of complement factor H can be a risk factor for macular degeneration. So complement inhibitors may improve geographic outcomes and improve this advancement to vision loss from dry macular degeneration. The GATHER2 study for dry AMD is using a drug called Zimura for geographic atrophy. This is a phase 3 multicenter randomized double-masked sham-controlled clinical trial to assess the safety and efficacy of intravitreal Zimura, which is a complement C5 inhibitor in patients with geographic atrophy secondary to dry macular degeneration. There will be 400 patients enrolled. This study is currently enrolling, and patients that will be randomized to study drug injections every month for 12 months, and then re-randomized to either receiving the Zimura every other month or a sham on non-Zimura months, or they'll receive sham injections every month through month 23, so it's a 2-year study. Enrolled patients all return monthly, and again, it's an intravitreal injection of the study drug. The eligibility requirements for this study: aged over 50, so this is a study which allows younger patients to be entered, and they do not need to have center-involved geographic atrophy. So this study is looking at prevention of vision loss due to areas of geographic atrophy. So it's looking at decreasing the advancement of the disease. Again, they can't have had any prior treatment for dry or wet macular degeneration. They can be on oral supplementation. There's another study looking at an anti-C3 cyclic peptide to inhibit complement C3. We are actually not doing this study, but it's another pretty interesting study looking at intravitreal injections every 1 to 2 months versus a sham. The study's in phase 2 in other centers, and it has shown some positive results with 47% reduction in lesion growth in the monthly injection group at year 1. So that's a pretty significant reduction in growth. However, there was evidence of some increased risk of converting to wet macular degeneration. However, the positive results outweigh the negative, because once it converts to wet macular degeneration, we can actually treat that with our standard treatment. So this study is going forward now with a phase 3 study. This is just a summary slide on the complement inhibition. There are many complement inhibitor therapeutics, such as the anti-C5 and anti-factor D. Some of these drugs have failed to improve the GA outcomes in both phase 2 and phase 3 trials. But there are other options, such as the anti-C3, which are a novel approach to reduce geographic atrophy growth and improve advanced dry AMD outcomes. Complement inhibitors have a significant potential as treatment options for advanced macular degeneration. This is still an interesting study that is still ongoing. We are not actually doing this study, but it's a phase 1/2 study that's being done at several centers, mainly in Southern California, where it was developed, evaluating the safety and feasibility of a subretinal delivery of human embryonic stem cell-derived RPE, or retinal pigment epithelial cells, in patients with advanced dry macular degeneration. They have finished their first cohort, who had very advanced disease, and they are working on their second cohort now with less advanced disease. But you can see a picture of the implant next to a penny, and it's a very, very tiny implant which is implanted in the eye in the area of the dry macular degeneration. Tetracyclines are still being used. These are drugs which are readily available, similar to the Metformin, and minocycline is a tetracycline derivative. We are actually not doing the study at KC, but there are several centers around the US still looking at these drugs. And it has been demonstrated that minocycline protects the human RPE cells against oxidative stress. So there's an ongoing phase 2 trial evaluating the use of oral minocycline and doxycycline in the treatment of AMD patients with geographic atrophy, to evaluate if these drugs can slow down the expansion of the geographic atrophy lesions. The study results are expected sometime in 2022. I'm going to switch gears and talk some about the studies for wet macular degeneration that we have talked about before, and do an update on what's available and what's new now. The latter study is a very exciting sustained release device for ranibizumab, which is one of the drugs that we use for wet macular degeneration. The phase 2 study of 3 different formulations of this port delivery system compared the delivery system to the intravitreal injections that are given monthly. This is a refillable, non-biodegradable, long-term drug delivery implant, which is implanted into the eye, and it's aimed at providing sustained drug release. You can see it next to a dime here. It's very small, and there's a schematic of how it's implanted into the eye next to the pupil. It uses a standard surgical technique in the operating room to implant this. There's no sutures, and then we're able to refill this in the office with an as-needed injection. The positive results from the phase 2 study showed that the implant allowed the majority of patients to go 6 months or longer without needing the implant refilled. The phase 3 study, which is called Archway, is underway, as well as the Portal study, which took all the original patients and moved them into a long-term follow-up. These patients are all now being followed, and no other patients have been entered into the trial. The data analysis thus far has shown this device with ranibizumab to treat wet AMD to be successful in extending the length of time between treatments. So at this time, that device is not readily available. However, my assumption is because it has shown such good results that it will be available probably within the next year. The next thing I just wanted to mention is gene therapy. There's a phase 2A randomized controlled trial of subretinal administration of a gene therapy agent. This study has been going on at other centers over the past year, and definitely shows that there are fewer ranibizumab treatments required when this is compared to monthly ranibizumab, and it does support the role for ocular gene therapy as a potential approach for long-term treatment of macular degeneration. The other thing I'm asked a lot about is stem cell therapy. So there are 3 types of stem cells which are being looked at right now: pluripotent stem cells, fetal stem cells, and postnatal or adult cells. Currently, there is no FDA-approved stem cell treatment for retinal disease. Pluripotent stem cells derived from the RPE. There are some early phase clinical trials which have shown patches of increasing pigmentation after transplantation in the subretinal space. Currently, we are not doing that study at KC. In fact, we're not doing any stem cell studies here, but there are places still looking at that, and that is a potential treatment in the future. There are, I'll talk a little bit next about the studies that have shown no effect that we were doing. One of them was with a drug that looked pretty exciting last year called Abicipar. This was a new class of small molecules known as DARPins. And these drugs would bind soluble isoforms of VEGF-A. We actually were doing the study here, and that study was completed. However, it did not receive FDA approval due to increased inflammation during the treatment. And I'll mention the other drug there. This is the 4th drug for macular degeneration, which actually has been FDA approved. It's called brolucizumab or Beovu. It's a single-chain antibody fragment, which is a VEGF inhibitor. The phase 3 trial was completed, and the drug was found to be non-inferior to Eylea. And this drug was only required to be given every 12 weeks versus Eylea, which was every 8 weeks. There were positive outcomes for the low and high dose groups. And it was actually FDA approved, but there are now ongoing post-marketing concerns with significant inflammation in some cases. So this drug is actually not being used at KCI, as we do not have it approved up here because of these post-marketing concerns. Another study that we started and that has actually been completed was the Graybug Macular Degeneration Trial. This was a very novel depot formation of an anti-VEGF agent, which was compared to aflibercept, and it utilizes microparticles to aggregate into a single biodegradable depot, and I'll show you a photograph of that depot. So this is the agent actually in the eye. It's the yellow agent. So this agent actually is injected and turns into a gel within the eye. And the gel is then slowly released over 6 months, as you can tell from the photos. The photos start at baseline with the injection, and then at 6 months when the drug is almost gone. The original study had positive results and showed benefit and is now moving into a phase 3 trial. And then we can talk briefly about some other agents. Squalamine is actually now in an eye drop form, and it targets multiple different VEGF as well as a couple other growth factors which are felt to be important in abnormal blood vessel growth. The phase 2 clinical trial was a randomized placebo-controlled trial, which showed benefit in vision with the addition of the squalane eye drop. The phase 3 showed no benefit to using the drop over the anti-VEGF injection alone. So that drug is no longer being used for macular degeneration at this stage. Another agent, which is a sustained release agent, is called, the drug is vorolanib, and it's being developed by EyePoint Pharmaceuticals. It's an oral, it was originally an oral tyrosine kinase inhibitor. However, it has now been put into a small injectable sustained release agent. And this is next to a grain of rice. It's very tiny, and it's now in preclinical trials. And I wanted to skip over a couple of slides and just go to the Microbiome Study, which we're doing at KCI, and this has been an ongoing study. And right now, I think we're only taking patients for the study who have dry macular degeneration. So if you're interested, contact Joan and we'll get you in touch with the people running this study. But this is to learn more about whether gut bacteria are different in patients with AMD compared to people without AMD. And again, right now we have enough wet AMD patients and we're looking for dry AMD patients. And this is basically the population of bacteria that live in the intestinal tract. And this is how you qualify, and Mitch and Scotty are the two study contacts. There's basically a consent, a 6-page health questionnaire, a one-time blood draw, and a stool sample collection. And there's a lot of studies that have had negative results. This is basically a very small list of them thus far, and we've been involved in a lot of those studies here, but you have to do some studies with negative results to find studies with positive results. So this is an ongoing process, and I thank you for your attention.
Thank you, Dr. Flaxel. We can move to Dr. Bailey now.
Great. Hello, everybody, and I'm going to share my screen here. Okay, good. Good morning. This is Steve Bailey, one of the clinical faculty here at the KCI Institute, and I'm going to talk about age-related macular degeneration advances in imaging. So the goal for this discussion is to highlight and show each of you some common retinal imaging that we obtain regularly for our clinical practice and for research for age-related macular degeneration. I'd like to explain why different imaging types are useful and how over time different imaging platforms have transformed AMD diagnosis, management, and our understanding of the disease itself. I do have a lot of images and pictures. I'm hoping to show all of you what we see as clinicians and as researchers. I'm also going to try to explain and talk about a lot of these things because I can understand some people may have a hard time seeing these pictures depending on the resolution of your computer screen and how they look. So there are a lot of photos, and I hope this works. So one of the, probably this most simple and fundamentally important imaging that we've used throughout history the last 30, 40 years have been just the color fundus photo. Here's a color fundus photo of the right eye, and the macula is the center part of the retina. That's just anatomy, just like your elbow. The macula, everyone has a macula, and that is where their central vision is. And that's the area that's affected by macular degeneration. The fovea is the center part of the macula, and that's where the highest resolution is for our central vision. The kind of yellow structure on the right is the optic nerve, and all the red lines are blood vessels called retinal blood vessels. Now, fundus photos are really important for us because it's really bright for us to look at the retina. And this gives us an opportunity to look at the retina and study it and examine it, over hours, which you would never let us do if we were trying to shine a light in your eye, to do that sort of detailed analysis that we would need to do as we learn about these diseases like macular degeneration. Additionally, if we have a color photo, we can follow changes over time and really learn about disease. So here's a color photo of an eye with wet macular degeneration. If you look at those little yellow spots, those are what are called drusen. Those are the hallmark findings in age-related macular degeneration. And if we see those as a clinician, that's how we make the diagnosis. Now, you'll also notice that there's some red splotches. Those are areas of hemorrhage, and this is a case of wet mac degeneration. Now, just seeing blood in the retina doesn't mean you have wet mac degeneration. There can be other causes of bleeding, and I'm going to go through some other imaging we use to confirm that this blood is from wet mac degeneration and not something else, say, diabetes or other things that can cause blood in the eye. Here's a color photo of another type of advanced mac degeneration that causes vision loss called advanced dry mac degeneration. And geographic atrophy is a term that we use when patients' eyes have a loss of their photoreceptor cells and the retinal pigment epithelial cells. And I hope you can see in this picture that is highlighted with that blue arrow is that there's sort of a circular area in the center where the retina is more pale. It just looks slightly different than the rest of the retina. There are lots of little yellow spots of drusen, which is what you would expect, but that pale area looks pale because that's where the important cells of the retina have died off and don't function. So that tissue is not useful for this person. Now, we're very familiar with the age-related eye disease study. This is the AREDS study. This is what gave us the very useful information about how antioxidants and zinc and beta-carotene lutein and zeaxanthin are useful to prevent mac degeneration. But one thing that maybe not everyone realizes is how important annual photographs were and how much information we received from these. In this study, over 4,000 patients had clinical photographs every year, and these were followed for 5 years. And that's really how we learned about this disease, and we've identified risk factors. These risk factors include looking for these features when we look at the eye: drusen, pigment changes, or atrophy. Again, atrophy is thinning of the retina, and these are found in about 85 to 90% of patients with macular degeneration. And based on these pictures that we had to review, they came up with some definitions. And so early macular degeneration is if you have really tiny, small drusen. Intermediate macular degeneration occurs if you have many drusen or some larger drusen, or you have some thinning in the retina that's not in the center called non-central geographic atrophy. And Dr. Flaxel reviewed advanced forms of macular degeneration, which includes the wet or the central geographic atrophy, or which is advanced dry macular degeneration. So I'm going to show you kind of what some of these differences look like with a technology like color photo. So this is the small drusen, and you might not even be able to see it because they're so small and tiny. So we know from the AREDS study, after reviewing these clinical photos, that if you have those tiny little drusen, the odds of you losing vision loss is 1.3% in 5 years. Very low risk. And that's why you wouldn't even need to take the AREDS vitamins, because you're at such a low risk that the vitamins wouldn't even necessarily help. Healthy diet would be recommended if you just have these tiny little drusen. Here's an example of many intermediate drusen. You can see these yellow spots are larger, and there's many of them. If someone presents with this type of feature, they'll have a higher chance of vision loss, 18.3% chance in 5 years. Pigment changes are areas that are changes that occur in the retina where you get these darker little splotches, as you can see with this blue arrow showing some pigment changes in a macula. So what we've learned after kind of analyzing these thousands of pictures over many years is that we can create a severity score that stratifies your risk of developing vision loss over time. And we can do it per each eye. So the little graph on your left shows that we look at the right eye and we see, is there a large drusen, yes or no? If there is, you get a point. Are there pigment changes, yes or no? If there is, you get a point. We do that for each eye. If you've had wet macular degeneration in one eye, that would count as 2 points for that eye. And so what you can see is on the scale below, depending on if you have 0, 1, 2, 3, or 4 of these risk factors, that's your chance of advanced macular degeneration and vision loss in 5 years. So if you have 4 risk factors, you have a 50% chance of vision loss. And so again, the reason I'm showing this is that this wouldn't be possible without imaging technology. And this was imaging technology from the 80s and 90s, which is the color photograph. There was a question, how, do most people lose vision if they have macular degeneration? We know that from the AREDS studies, which is the best prognostic indicator available, that only a fraction of patients with mild small drusen or early AMD lose vision. And of those who end up having intermediate, those are the larger vision, still only 12% of those will develop wet macular degeneration, and only 6% will develop dry macular degeneration. So it's not guaranteed, even if you have some intermediate drusen, that you would lose vision. In fact, many people don't. So here's an example of a color photo, and this shows some of the limitations of color photos. So this is a patient what we think might have wet macular degeneration because they've had vision changes, but we don't see a large area of blood. But there's a sort of a strange gray area where it's not quite as clear as highlighted by that blue arrow. And so the question is, could those abnormal blood vessels, those are what cause the wet macular degeneration, could those be present? So the way we find out historically, the gold standard has been we use fluorescein angiography. This is an organic dye that's injected intravenously, and it absorbs blue light from the camera. And then the dye in the retinal blood vessels emit a yellow light that can be seen well with these special cameras. Now this angiogram usually takes about 5 to 10 minutes for the blood to circulate the dye and for us to get a series of photos over time. Because we are injecting a dye into the vein, there is some side effects that include 5 to 10% of people may have some nausea or some vomiting, and rarely there can be a severe allergic reaction. Here's a picture of a normal fluorescein angiogram. What you'll notice is that in these pictures, the retinal blood vessels are clearly visible and they appear white, and that's that sort of luminescence or fluorescence from that dye that's inside those blood vessels. And we can see much better resolution than we could than just the color photograph. Now, because we're looking for abnormal blood vessels in wet macular degeneration, this technology is very useful. Because these blood vessels are underneath the retina, they're very hard to see unless we use some special techniques. And so, again, this may be hard to see, but that orange arrow points to that little kidney bean-shaped area in the macula. And that's how we as clinicians would identify this as wet macular degeneration, because that kidney bean-shaped area should not be there. And those are the blood vessels that are causing the vision changes. And we've now made the diagnosis of wet macular degeneration using this invasive dye test. And again, this is the gold standard for diagnosing wet macular degeneration and has been for many, many years. However, there are some new technologies that we've been using, especially over the last 10 years, that are changing how often we need to do the invasive dye tests of fluorescein angiography. The most common test we use today is called optical coherence tomography. This is a scanning tool that is very quick and easy to obtain in their office, and certainly if anyone's been in office and they have the diagnosis of macular degeneration, they would have had one of these scans. I'm not going to get into the details of this technology. Think of it sort of like an ultrasound. We're used to thinking about how ultrasounds work, where sound waves can safely travel through tissue. For example, if a pregnant individual, we know the sound waves can travel through the abdomen, and then the sound waves bounce back. And based on special time delay and amplitude changes in the sound, we can get images of a baby in utero. This is sort of the same idea, but instead of sound waves, we use light waves from a special laser that goes into the eye and then bounces back, and we use a stationary reference. And again, based on the sort of the time delay in how the light bounces back to the special cameras and tools, we develop images or cross-sectional images of the retina. This is highly sensitive, and we can see high-resolution images to the level of histology. And so we're seeing layers of cells. We're talking about fractions of millimeters. And this is all obtained in our clinic without any invasive dye or any contact on the eye. And we get these scans in seconds. And this has really revolutionized how we evaluate retinas. Currently, the person who invented or co-invented this technology works at OHSU, and so we're very lucky to have him on our staff because this has literally revolutionized ophthalmology. I'm going to go through some examples of what macular degeneration looks like compared to a normal scan on an OCT. So this first scan of your macula, the scan up above, is a normal appearing OCT, and you'll have that little dip in the center. That's called the fovea. The lower picture shows intermediate dry macular degeneration. So those little yellow spots, when we look at these images in cross-section, you can see that the white line in the bottom is has some lumps and bumps, and it's not smooth like the image above. And those are what drusen look like with this particular technology. So that's an example of dry macular degeneration with drusen with an OCT. This is an example of a normal OCT above. The lower picture shows advanced dry macular degeneration where there's geographic atrophy, where there's thinning of the retina. And you'll see those white lines are no longer continuous and there's missing tissue. And that's tissue loss. The cells in the retina have died off. And so the tissue is not healthy there and the vision is poor in the region of the retina. Here's an example of wet macular degeneration with the lower slide, where you can see there's a large underneath the retina, which is that sort of bright sort of blob underneath the retina. And because of that, this retina is not functioning well. And again, the cause is from wet macular degeneration. One of the most important uses for OCT is to help us not only make diagnoses, but to treat macular degeneration, to evaluate our treatment. So this is a patient with wet macular degeneration, and that dark area on the top image with the orange arrow shows an area of subretinal fluid. The fluid is a result of abnormal blood vessels. We can oftentimes just look at this scan and we can kind of make the diagnosis of wet macular degeneration without doing the dye test because we're pretty accustomed to evaluating these scans. But what you'll notice is after the treatment on the lower side, you can see that dark area is much better. So this tells us that the treatment is improved. There's still some of the darkness on that lower slide, so the disease is still active. So when the patient returns a month later and after another treatment, we can see that all the fluid is gone. So we say this is well treated, but it's not cured because those blood vessels are probably still there, but there just isn't any fluid underneath the retina. If we didn't have these scans, we would really be there's no way for us to know if these patients were adequately treated. And typically what would have happened is when the studies first came out, we didn't use OCT back in 2008 to 2010 to evaluate eyes that are under treatment. So patients would just get a treatment every month, no matter what. And the studies would typically last 2 years. And every 4 weeks you get a treatment. We're lucky now we have this technology because we can individualize therapy. We can find someone who may need a treatment every 8 weeks or every 10 weeks. Or we may also be able to identify those patients who truly need to come in every 4 weeks because we can tailor the treatment based on these images that we have. So I'm going to move on to some of the newer technology that's just becoming more popular. And this is called OCT Angiography. OCT, so it's the same technology that I was just talking about in terms of using light to scan the retina and allow us to get information from it. But angiography means that we're able to look at blood vessels in a new way. The nice thing about this new technology, it doesn't require a dye. So there's no allergic reaction, there's no vomiting or nausea. This is a developing technology, and we are using our studies here at the KCI Institute to prove that they're useful in the clinical setting. Another thing that's important to note, with the help of David Wong, Ali Jia, and Ricky Wang, who previously was here at OHSU, that this technology was invented at OHSU. The two main algorithms that are used in many of the platforms were invented here in 2010 and 2012. This is one of our initial high-speed swept prototype OCTs, and this is the laser scanning unit. And this can do about 100,000 scans per second using these extremely fast lasers. So it's a pretty amazing technology. Again, I'm going to briefly go into the way this works, but what it does is it does a B scan at every position, and then it repeats that scan at that same position over time. It then does that same process in 200 different positions, and all of these scans are obtained in only 3 seconds. Newer technologies even have carrying faster. So how does this work? Well, basically what it does is this technology separates moving tissue from static tissue. And if any tissue has moving red blood cells in it, we separate that from any tissue that doesn't have moving red blood cells. And then there's special algorithms that can assess this data and give us, select out where the moving red blood cells, and then we can get an angiogram. So in the picture of your right, you see retinal blood vessels. Again, there's no dye. This is just an image, a scan that we obtained from that. We can also identify where the flow is in the cross-sectional OCT or in the lower one. So we can see where flow is related directly to the structure or the anatomy of individuals' retinas. And this is very useful because we can now diagnose macular degeneration, wet macular degeneration, without the dye test using these scans by detecting moving red blood cells. Now, the choroidal neovascularization looks different than our normal red blood vessels. And so on your left, that's what's called a normal fluorescein angiogram. That's the old way we used to diagnose these. And then in the right, you can see that the vessels match up, circled in yellow, or in the outer retinal slab window, we can see the retinal blood vessels from the choroidal neovascularization. This also helps us identify certain types of macular degeneration a little bit differently than we could before. This is a special type of wet macular degeneration called RAP, a retinal angiomatous proliferin, that occurs actually in the retina instead of the choroid. And we can detect these with this technology. And in some cases, these eyes respond better to treatment. And in this case, just after a single treatment, all the flow was gone and all the fluid was gone. And we're more likely to be able to extend these patients to be treated less frequently. And we're better learning how to identify these eyes with this new technology. As you can see, this is sort of a summary of a number of different studies that have been done over the last 5 to 6 years that have been studying how good is this technology at detecting wet macular degeneration. And it turns out it's about 90% of the time we can detect it compared to our older technologies. And most of the time when it says there are abnormal blood vessels there, it's accurate. Nearly 100% of the time we're not coming up with false negatives. So this technology is rapidly advancing, and it's becoming more and more reliable for making the diagnosis. This is kind of an interesting case that we've discovered with this technology. This is a patient of mine whose other eye has wet macular degeneration, and they were enrolled in our study getting this new technology. And the left eye was 20/20 and had no problems and had just some pigment changes in drusen, and nothing was found on the angiogram. But our OCT angiography actually detected this person had new blood vessels that shouldn't be there, and that's the yellow vessels that you see there. So this is someone who's asymptomatic, who has new blood vessels that shouldn't be there, but they don't have fluid or hemorrhage. So we're not sure if we should treat these eyes or not. So we followed this person, and over 15 months, these abnormal blood vessels have slowly grown, and this person so far has had no vision changes from them, and so we're continuing to monitor them. And what this is called non-exudative CNV. And this means there are some patients with macular degeneration that get some blood vessels that shouldn't be there, that behave in a more benign manner, meaning that they're less likely to cause hemorrhage and swelling and vision changes. And you can detect this with fluorescein angiography and OCT and another imaging modality called ICG, but it's many, many scans and it's hard to detect them. But with OCT angiography, you can see them easier. And so we're detecting more of these than we thought were there before. In fact, about 6 to 20% of eyes where the other eye has wet macular degeneration, we're detecting some of these abnormal blood vessels. However, they're not all benign, and 20 to maybe up to 80% of these may actually convert to the wet type of macular degeneration where patients can have vision loss. This was a result from one of our studies where we had 8 out of 10 patients eventually did develop the wet type of macular degeneration. So this is useful, though, because we can follow these patients very closely and treat them as soon as needed to prevent vision loss. We're finding that we may be able to identify those blood vessels that are at risk if they grow really rapidly. So in this series of pictures, you can see the blood vessels are enlarging over the first 6 months. And then we found a little bit of mild fluid. The patient didn't have any vision changes, and that allowed us to treat this eye before they had vision loss. And we were able to maintain vision afterwards with our regular treatment for wet macular degeneration. So in summary, I just wanted everyone to kind of understand how important imaging technology has been for our field. Without these ability to detect the features of different diseases, we wouldn't be able to develop the drugs and assess for the treatments that we're able to do. I can't think of another field in medicine that has access to this type of technology every day in their clinical visit. You think there are fantastic MRIs and CT scans, but those aren't used on a regular day in and day out basis, whereas we're able to get amazing information that is really useful for us as clinicians. And so, I feel kind of lucky to have this as an option for me. We're combining new technology with the new medicines, and that's improving our outcomes. And imaging technology will be crucial in discovering whether new treatments for dry macular degeneration in the future are effective. This final photograph is all of the collaborators in the COOL lab, and the COOL lab is the lab at the KCI Institute that's developing this new technology. Including are some study coordinators, and so some of you who are in my studies may recognize some of these folks who are meeting you and helping us with getting some pictures. So that's my presentation, and Dr. Flaxel and I are open for any questions. I'm going to stop sharing my screen, and I can open up with one question. We had a question that was emailed beforehand about, there's a different type of macular degeneration called myopic macular degeneration. Myopia is a different condition entirely where the eye is longer than a normal eye. And so these patients need strong contacts or glasses to have a focused image. But not only do they need strong contacts or glasses, they're at higher risk for a type of macular degeneration that's very similar to routine age-related macular degeneration, because the retina is sort of stretched and thin. And they get a lot of the same features. They can get features like geographic atrophy, which is similar to the dry type of macular degeneration, where spots can degenerate over time. And they can also get wet macular degeneration, where blood vessels grow and they can have hemorrhage and swelling. And so the two diseases are very similar, and they have similar ways that vision loss can occur. There's no evidence vitamins play a role in myopic macular degeneration, so we tend not to recommend vitamin therapy for that. Myopic macular degeneration is more of a mechanical stretching of the retina and less of an inflammatory process. If there are new blood vessels, we treat that as we would regular age-related macular degeneration with the anti-VEGF injections. One difference is for patients who have myopic macular degeneration, if they have a really long, narrow eye, or have what's called a staphyloma, if their eye, instead of being round-shaped, is shaped more like a football, those tend to be eye progress more. So there are different risk factors with those eyes. The treatment's a little bit different, but in terms of preventative aspects, we don't know much about smoking or nutrition, but that's probably less involved compared to age-related macular degeneration. And there's no other new therapy, other than, monitoring them for the wet type of myopic macular degeneration.
Thank you so much for addressing that one, Dr. Bailey. Sarah, if you could please pull up that screen for me, or that slide. We did have a question regarding, regarding how to get involved in a study. And I know, Dr. Flaxel, you spoke about this a little bit. And for everybody, if you wanted to get involved, please feel free to email Joan. That is the KAHNJ@ohsu.edu here up on the screen. They also added, what does insurance play into the study? Do you happen to know that, Dr. Flaxel or Dr. Bailey?
So if it's a clinical trial where we're looking at new drug treatment, mainly the ones I talked about, then the study is covered by the sponsor of the study. There are some of the studies which are like the Metformin trial, where the follow-up in that study is standard of care, so that's billed to the insurance. However, I've been able to provide the actual drug to patients with some funds that we have available. So depending on the study, most of the studies are going to be that are involving a new treatment. Well, the treatment is covered by the treatment and all the visits are actually covered by the sponsor. Dr. Bailey's studies, I'm not sure, Dr. Bailey, do you want to talk about your studies?
Yeah, so we're doing imaging studies, and so there's no extra cost. We try to coordinate our visits with a normal routine clinical visit, so it's not anything additional than in terms of cost, in terms of what they normally would have had as part of our routine care. So typically, there shouldn't be any additional study costs for us for our studies.
Wonderful, thank you. We did have another question come in. Has any study been done with deep red near infrared light?
I don't know of any that have been done with that. Steve, do you know of any?
No, they were looking at visible light OCT, which is sort of in a different wavelength. And a lot of it sort of depends on the reflectivity of the tissue and what you can see with that. And so I'm not aware of that specifically. So no.
Okay, thank you so much. And I apologize if I'm asking any questions that have already been discussed. I didn't hear anything about what's good and to eat and what food should be avoided. And we had a question regarding that. If you didn't speak to that, could you mention?
So the foods that are good, the nutrition is very important, and the foods that we feel are good are those that are high in the green leafy vegetables, spinach, kale, broccoli, those kinds of things, which are high in the lutein and zeaxanthin. The things that the newest study that looked at, it was actually, I talked about it kind of early on in my talk. The AREDS and the AREDS 2 study was reevaluated, and it's felt that people should avoid high-fat foods. But again, there may be some genetics that play into that as well. So basically green leafy vegetables, and there is on our website, I think on our website, because we have a handout in the clinic as well on foods that are good for the eyes and foods that are have less of the antioxidants in them. So that's available, I think, on the Macular Degeneration website as well.
Wonderful, thank you so much. And I think we have one more question that was not answered today. This one reads, I am a retired OD and founded and help run a low vision support group at the Springs Retirement Community in Eugene. We're always looking for new educational resources. Could you recommend videos on AMD that we could show to our participants?
So I actually asked Joan about this, and we don't have any specific videos that we use for participants. I think Joan was going to try to email that person directly with some ideas as to where they could find more information.
Oh, yes. I do remember that. I apologize. I believe all the other ones were actually answered throughout the talk, but if you did send in a question and you did not get an answer, please do reach out to Joan at kahnj@ohsu.edu, and she'll get those answered for you. I also know that there was a couple people that were having issues with viewing the slides, and we believe that was because if you were logging in through a mobile device, that's not really compatible. So we will have this available to view and listen later on our website. That's also still on our screen. So, but if you can't see the screen, it's www.ohsu.edu/AMD. And you can email Joan as well to get that. And with that, looks like we are right at time. So thank you all so much for joining us. I apologize. Sorry, that was that. Thank you, Dr. Bailey and Dr. Flaxel, for your time and insights today. Don't forget to join us next Saturday at 10 a.m. for low vision adaptations for the home, and again at 1 p.m. for reading and with vision loss. Tools and technology for accessing the written world. All right, thank you all so much.